more.
Thank you.
Right. Also, if transcription can be useful too. I just recorded a meeting and then I realized I needed to transcribe it and had to turn that on too. So if you, it helps to do it at the outset. Any rate, that's your choice. Yeah. So I put together this talk, partly new survey of needs in stroke and with a little bit of a core of research that I've done to give some perspective on scientific needs. So I didn't want to ignore scientific needs because there's still a lot that needs to be done in terms of understanding recovery of function after stroke. But I'll get right into it. This is a outline. So it's actually going to start out not specifically about stroke, but about transcranial magnetic stimulation, which I think is an interesting example of how neurotechnologies develop. Then talk about acute stroke needs. And I mean, I have in the past worked in acute stroke. I haven't done it since I came to Pitt, really, clinically. But there are some very interesting technological needs and developments in that area too. And then, from my own perspective of going from PET to DNA, my first introduction to stroke recovery was using positron emission tomography, and now we're using some genomic techniques. So all for testing a hypothesis about how does the brain reorganize to improve function after a stroke diminishes that function. Robotic rehabilitation, which I think is another interesting arc of technology in the stroke recovery world, and then talk about how it can enhance the effects of something that's already known to improve function after stroke, which is practice. It improves function in general. Um, and I'd be remiss if I were in Pittsburgh and not talk about BCI and AI in terms of control of assistive devices. I don't do a lot of that. I have some relationship to the BCI project at Pitt and even at CMU, but I think it's definitely worth mentioning, and then sum up some potential needs in stroke. And the other thing is, so I think this is meant to be a discussion, so I can't see all of you. Please feel free, and actually, I would even appreciate interruptions and some discussion about this. I will ask some questions, so I think it's better to keep it interactive. I mean, there's definitely something lost, except for convenience, in terms of doing this as a completely online activity.
And if anyone doesn't have a microphone or prefers to put your question in the chat, I'll be moderating that and I can pose the
Okay,
question.
that'd be great. Thanks, Robbie. All right. See, I won't be monitoring a chat. It's just too much multitasking. Um, yeah, so the principle of TMS, transcranial magnetic stimulation, is Faraday's law of induction, which is actually, did I miss the? No, I had a timeline. Okay. Faraday's law of induction, which is that if you have a changing magnetic field in time, that's the dB. Um, then that will be actually opposed by a changing electrical field that has a particular geometrical configuration implied by the curl operator. So that, essentially it does really, in this case, it really does mean curl. The electric field lines curl around the changing magnetic field lines. And so this is a way to induce electric fields with a magnetic field. So this is obviously an old principle. I think, yes. So next, if you look at the timeline, actually, I don't have Faraday's law in there, but it is old. And and so this looks at a timeline taking up to 2017. So the discovery that nerves have some electrical principle is 1790s. So that's obviously quite a while ago. Electrical brain stimulation is from the 19th century. And in fact, actually, electroconvulsive therapy, developed in the 20th century, is a technology that really used this effect, but not a lot of other applications for this. Um, so then we'll talk a little bit about like how magnetic fields were first used for nerve stimulation, and mostly in animals. And then that got to humans. But you can see that it actually took quite a while before you get to FDA approval. So Canada approved TMS therapy for depression in 2003. 5 years later, the United States did, and insurance companies only started to cover it in 2013. And very succinctly, new medical devices require FDA approval, um, payer coverage, and provider acceptance. That's like the tripod under which like new technologies need to stand. It's not really that long ago. And then wide use is only about 8 years ago. Okay, so here's early TMS. D'Arsenval is a French scientist who discovered that if you discharged a static charge into a big spiral coil and stood in it, you would see flashes of light. So these are called phosphenes. There was another inventor around the same time who actually discovered this effect. It turns out actually this effect of you can induce phosphenes by putting a TMS coil on the occipital lobe of the brain, but these phosphenes from these kind of whole body coils were most likely from the retina. But the retina is still part of the central nervous system, so that counts. Um, so, it's really just a demonstration and it didn't go anywhere. I mean, you probably know that there was a kind of like a kind of business of just going around and showing off magnetism and electricity as, exciting technologies. But I don't even think that this was even demonstrated. It was a little bit cumbersome. The D'Arsenval, that was called the D'Arsenval spiral. So then actually this gentleman, Reg Bickford, was actually one of my instructors at UCSD, so University of California, San Diego. One of the nice things about being a medical school in San Diego is you had a lot of emeritus professors who'd come to San Diego to teach for the weather. We had a great surgeon from Calgary who I've learned like a third of my anatomy from. But Reg Bickford was there mainly as an epileptologist. But he demonstrated, and I think it was really started to develop in the 50s, that you could actually create pulsed magnetic fields oops, sorry, um, with a large a machine that capacitor that would discharge through a relay into an electromagnet and get twitches. The downside of his machine were really twofold. One was just a technology issue of the time that the switching of these high voltage um, the high voltage and the high currents uh, created smoke as they kind of went across the relays. So the stimulus would smoke with every pulse. And the second thing is that they designed the electromagnet just to be integral to the machine. There's no cable, so I think early on they did like experiment with like putting their head on it and seeing what happened, but it wasn't really very convenient for stimulation. And really these stimulators went nowhere from in the 60s. So even though, like as I mentioned, with electroconvulsive therapy, it's known that you could non-invasively put electrical currents through the brain and get an effect. They they um, they didn't actually know if you could reasonably focally stimulate the brain with electrical currents from the outside, and so. William Levy at couldn't find the picture of him, but he was at this medical center, the University of Missouri Medical Center, demonstrated that you could put an electrode over the motor cortex, so posterior frontal cortex, and he actually had his ground, there was, other electrode on the palate, and send a pulse of electricity through there and get a motor evoked potential. And th this was actually used in scientific studies as well. I don't know if can anyone guess what the main downside of this technology is?
Movement in the pharynx.
Yeah, well, it was in the pharynx in this case, but you don't have to, of course, you don't have to put the electrode. Well, Polka, it's not fair. You know what the main downside of this is. Um,
We have
but
someone
yeah,
in the chat saying scalp pain.
pain, right? Yes, pain, right? So it's painful. Polka Grover is working on a less painful method. So it's interesting, as a technology, how these technologies come up. That I mean, I've actually never had transcranial electrical stimulation. I've seen it done since the late 90s. So it still is a useful technique in many ways. I won't go into the details of it, but the point is that in this was really started in the late 70s and early 80s, and so this was useful, um, but also painful. So putting the two things together, that this magnetic stimulation um, already knew that it was less painful for stimulating peripheral nerves, and the fact that you had a technology to non-invasively activate the motor cortex with electricity, um, I think was very fertile ground for developing a technique that used magnetic stimulation in the brain. And so this is a kind of modern version of the company that is actually a successor to Jolinas and Barker and others in Sheffield, England, who developed the first um, practical transcranial magnetic stimulator. Actually, interesting, ironically, so this particular stimulator is FDA approved, but for peripheral nerve stimulation, not for brain stimulation, which I think almost nobody uses for peripheral nerve stimulation. It's a pretty good spinal root stimulator as well. Um, the original device didn't look too different than that. I didn't put in a picture. So it was in the mid 80s that they developed it. And but it's not this one doesn't smoke every time you give a stimulus, and the reason is because of high voltage silicon controlled rectifier switches, right? So it was development of a technology in the interim between Bickford's stimulator and this stimulator that made it practical. You can, in fact, I've seen Chip Epstein at Emory builds his own stimulators. You can build a stimulator with about $50 worth of components, and he builds his into Home Depot toolboxes. The circuitry is very simple. I mean, it's essentially a large capacitor and a power supply, and then a switch that just discharges the capacitor into the coil. There are a lot of safety devices, of course, and other little bells and whistles on the stimulators, but that's really all they are. So these are useful for activating motor cortex. So here you see me doing TMS in Baltimore. You can use neuronavigation to precisely place the coil over the head. And the basic technique, though, which was found very early on, is that if you activate TMS so this is the artifact that's in an EMG recording. Then with some latency, you'll get motor evoked potential, which is a kind of compound action potential of from the muscle that's innervated. Of course, a muscle that's innervated by the nerve that's connected to the spinal cord that is activated by the brain. You can map what we call the hotspot, the best point for stimulation. You can find a threshold and a stimulus response curve or recruitment curve. The other phenomenon that are possible that you can measure with this. So here you see biceps in red and a finger extensor in white with a slightly longer latency due to mainly differences in peripheral conduction. Any questions at this point, by the way? Comments? Um, so there's some downsides to TMS, and it just represents like another opportunity that you can't really localize the magnetic fields to more at a depth versus the surface. So this shows the kind of profile of the induced magnetic field of a double circular coil, which is designed to have the two opposite windings that cancel each other out at a distance, but reinforce at the near the center. So you get this kind of peak, and which is a small peak. That's and this is just a profile across a double circular coil or a circular coil. Um, but you see, this is in millimeters, so you have a pretty widely distributed field. And because of the threshold phenomenon, you get activation only in a sort of central area, but that could be a fairly broad area. It's really hard to know. You can make the coils smaller, but the better localized, but smaller coils are weaker. But you can also get hyperacuity by moving the coil around. So if you have accurate measurement of where the coil is, you can move this peak like a few millimeters to the right and see how different the response is. There are other downsides to TMS that there's auditory and tactile input when the coil has a sort of solenoid effect. It moves when it's stimulated, so it creates sounds. The machine creates a sound. There's tactile input on the head. There's tingling on the scalp due to the electrical stimulation of the scalp, but it's not painful tingling in general. Causes muscle contractions too if there are head muscles there. And then there are variable responses all for all sorts of reasons. There's brain state differences. Of course, you can't hard to control that. Um, the fact that you're measuring something like a motor evoked potential so distant from the area of the brain that you're activating means that synchronization is an issue. You get some loss of synchronization of action potentials when you're down to the muscle level. So the even with the same amount of activation of upper motor neurons, you get variation in the activation of lower motor neurons and muscle. There's all the other variation that happens in the brain. Coil position, um, there are actually robots that will move the coil around the brain, um, but the accuracy is still based on stereotactic localization, which has it certainly has its downside. Even the brain moves when people's head position changes, so the coil position is a concern. I should mention too, like when we're talking about like potentials for technology, I would say without like being too judgmental that development of TMS coils has not really been a hot area of research. So most of the coils are circular, double circular, cone shaped. There's a bat wing style that sort of moves the wings out of away from the head. The handle is changed in a ways to let you position it better. But there hasn't been, I think, like the same level of work that goes into like tokamak um, magnets has not really been applied to TMS. There is kind of getting back to D'Arsonval, there is an H coil, a helmet coil that promises better depth, and it probably gives it, but it gives quite a bit of surface stimulation and lack of focality as well. So, I think there's a lot of room to for technology developments in TMS that hasn't happened yet. So. So okay, that's the part on TMS. So any questions or comments about TMS?
I guess I
TMS,
have a
yeah, good.
question of
Yes.
like, why is there not more development on it? Like, why do you're saying
Right.
there's lots of room for better development, so
I think
what is
so.
like
Right.
hindering?
Right. So I'm not enough of a, I mean, I don't know like how much the intrinsic limitations of magnets are the reason. I think the other problem, has to do with the fact that it may be a market issue, right? So, with all the something that was developed 40 years ago is FDA approved now for peripheral nerve stimulation, for which it's really kind of a straw indication, and used for depression. I think one company tried to get indication for mapping and tumor preparation, but I don't know how successful that's been. So I think it's partly like seeing the commercial needs for the technology, which I think at this point are still mostly scientific. That's one opinion. Yeah, so I don't really know. I've kind of asked that, around when I've met um, people in the companies and everything, but I haven't really heard too much about that. So I mean, I think, just like I think I was trying to illustrate by the whole example is like a lot of times it's really the combination of technology and the need for the technology that leads to the development. It's not necessarily that it isn't there yet, and yeah, but I'm certainly not an expert in magnet design, so that there may be some intrinsic limitations too, which would be an important thing to know. That's all. Thanks.
We do have a raised hand,
Oh,
William.
yeah, sorry. Yeah, Will.
Yeah, George, you said I think almost in passing there um, that it's not FDA approved for depression per se, but rather for something else as kind of a.
No, no, sorry. I meant to say that it is FDA approved for depression.
Oh, okay, all right, I misunderstood.
Right.
I apologize.
But not for any kind of like stroke, related work. That's what I meant to say, right? Yeah.
Got
So
it. Okay, thank you for clarifying.
and
Okay,
and those,
sorry, I
those
misunderstood.
right. And those TMS stimulators are mainly repetitive stimulators, that are often designed to be very simple, and easily used. So, yeah, so right. That's so a lot of times, like when we actually import them, and there are really no U.S. manufacturers of TMS either. So when we import them, it's always like a big deal. We have, now we have to send our IRB protocols, and yeah, so that's I think it is still a limitation. Of TMS. Okay, so I'm going to move on to just stroke in general. So I've tried to
Sorry,
make
can
this.
you
Yeah,
can you really quickly talk about the mechanism of why TMS is helpful for stroke or could be?
right. So that's a good, excellent point. So TMS has been used in stroke research like since the 80s. And so it's certainly true. Like if someone has a stroke, you won't get normal motor evoked potentials. And in fact, actually, right now there actually is a ongoing multi-center trial of which UPMC is part, called the Verify study, which is actually using that phenomenon of losing a motor evoked potential after stroke as a predictor of outcome. So that would actually make it, that would actually potentially give it an FDA indication for stroke as a diagnostic tool. So that's an important thing. In Germany, it's actually, I should mention, it actually is used diagnostically and for all sorts of diseases that affect the spinal cord. So it can be helpful in multiple sclerosis and myelopathies. So it's a useful electrodiagnostic tool. I think it's another limitation of device manufacturers often don't really have the wherewithal to actually get the indication. We don't have a U.S. manufacturer. Yeah, so that I think it illustrates the fact that there are a lot of limitations. Now, there are studies that show that repetitive TMS can be used to prime motor areas and enhance the effective practice. I think we still don't have a definitive study showing that. And so I've been to a number of meetings where we have a debate. Is repetitive TMS ready for prime time for stroke recovery? But usually the winning side of debate is not quite yet. So I mean, I'm working on it in my lab on a method for combining practice in a kind of novel way with stimulation of non-primary motor cortex. So hope to get there, but it's still pretty far away from FDA indication. Yeah. Sometimes these th things take time, and I think I'll illustrate some of those other things with the acute stroke. So for the sake of time, I'll move on now. But thank you for the questions. Um, Okay, so here's an example, totally made up, but I think very realistic. A 64-year-old right-handed woman is at home on the phone with her daughter when she's unable to respond to a question. She knows what she wants to say, but the words don't come out right. Her daughter calls EMS, and when they get there, they find her lying on the ground, unable to move her right side or walk. She regards them, but doesn't make any vocalizations. All right, so this is pretty typical example. So what's going on? Well, yeah, I mean, just to humor me, someone shouted, "What's what's likely going on with her?"
Might have a stroke.
Yes, stroke. Right. So it's certainly could be acute onset. There are other acute neurological conditions that can be mimics. And an example would be if a seizure. The daughter didn't see her. She could have had a seizure, and she could have what's called a Todd's paralysis, which can mimic a stroke. She could have low blood sugar. So, very surprisingly, and still not in a way that's totally understood, people with low blood sugar um, can actually have focal brain symptoms. So, one of the first tests, like, so one of the what diagnostics are needed before treatment, one of those would actually be a blood sugar. That's routine in every emergency room. It's been, it really doesn't get missed these days. So, right. So, but what other main diagnostic test would be needed before treatment?
At CT?
Yes, the CT, CT of the head, and just for the sake of time, I'll say why. So CT of the head is needed not to see if the person is having a stroke, because with an early stroke you don't see anything on the CT, or you may not. It's used to eliminate the chance that it's intracerebral hemorrhage. Because there's no real way to distinguish an intracerebral hemorrhage from an ischemic stroke, when it's caused by lack of blood flow early on. Hemorrhagic strokes tend to have a more gradual course, but this woman had a little more gradual course. She was just not able to speak at first, and then later on she couldn't walk. So that could be an expanding hemorrhage in the left hemisphere. But that's the chance that you can actually, well, the accuracy of getting it by history is not good enough, because when we talk about what treatments are possible these days for someone who's had a stroke. Yeah, like I said, I can monitor the
In the
chat.
audience, we're trying to make this interactive.
I know. It's always hard when you're okay. Actually, I can open the chat here.
There's nothing in the chat. Yeah, anyone feel
Okay,
comfortable? Okay.
all right. Well, I'll go ahead. It's there are treatments that can actually break up blood clots. So that's one. And we'll talk about some of the other treatments in a second. And the problem is that if someone is having a hemorrhage, the treatments that break up blood clots, or some of them, um, will yeah, blood thinners. Okay, McConnell, yes, the pulpit is added. Okay, now I see that. Yeah, so are the wrong thing to do when someone is having a hemorrhage, because they'll make the hemorrhage, any um, processes that are actually kind of forming a clot reverse, and then you'll get more bleeding. So that's really the important thing. So for that reason, there's this acute technology that's been developed, and what this is, a mobile stroke unit. This is, I believe, University of Texas, where for some reason Houston, well, Houston is kind of in the stroke belt, but Houston for a long time has had the most aggressive stroke treatment, and they also have a very high rate of hemorrhage, because of the demographics of the population. So for them, it's been particularly important to rule out hemorrhage as early as possible. And so they have this ambulance. You can see it's bigger than your average ambulance, with a CT scanner in it. So not a new technology. It's just like, let's take a CT scanner, which have gotten smaller over time, and put it in an ambulance. Um, and a few other areas have adopted this technology, but it has its downsides. You can't actually drive the ambulance while you're doing the CT scan. CT scans involve radiation. And so you have to shield personnel from the radiation. If they're doing this job day in and day out, they'd be exposed to a lot of X-rays. My understanding is that they have to be parked on level surfaces. So, like, think about this in Pittsburgh. That might be a problem. So, even though it does seem like a great idea, and the reason is because time is brain, and the faster you get a diagnosis, the better off the patient will do with the treatment. I was the first resident at the WashU program in St. Louis to actually give TPA, which is the clot buster medication. And when that patient came through the door, she was someone who had a hemiparesis, and not much else. There was a trauma that was expected to come to the ER, so they were holding the CT scanner open for that trauma patient because they didn't get used to the idea that stroke was an acute, event, and so that had to change that night to get access. I mean, little things like that, but you can get a CT scan pretty quickly in the emergency room, and you can be ready to give the treatment. But having it in the ambulance just means that you can know a little bit more when someone comes to the emergency room. So I won't belabor that. There are a lot of things about it. But here's another kind of technological development, and this is the portable MRI. MRI is been used for head imaging for fewer years than CAT scans. Um, but there are actually two downsides to this technology, to this portable MRI technology. One is MRI actually isn't as good as CT in detecting hemorrhage. The thing about hemorrhages is that they're made of blood, so they have more iron than the tissue that surrounds them, and it's very easy to threshold the images to show you blood as opposed to anything else. MRI also shows different characteristics of blood, but those characteristics change over time and can sometimes be um, confusing to read in terms of figuring out acute hemorrhage. The other downside is these portable scanners don't use superconducting magnets, so the magnets are actually weaker. They're just very strong permanent magnets, and so their actually resolution is poor. Um, but there are advantages that this can be moved around more easily. I don't know that anyone has suggested putting them in ambulances yet. They're pretty heavy, but I think maybe comparable to the portable CT scanners. Of course, having a magnet in a ambulance might very strong magnet and something that's driving around might be a problem too. But there's been a lot of excitement about it, but then also a lot of pushback about the quality of the imaging, and they're mainly being kind of marketed for this environment that you see right here, which is the ICU, where patients are unstable and it's hard to bring them off to a scanner. So successful treatments for stroke, um, it depends on the mechanism. And actually, just to mention that the treatment of the hemorrhagic strokes that you're trying to rule out by the early CT scan are actually an area of really more development and less certainty about what to do. You have generally a large bleed that's in a deep part of the brain. Is it better to leave it alone, to lower blood pressure, to maintain blood pressure, to take it out? There actually has been development of putting in TPA into blood clots in the brain to try to get them to clear out. But blood is very irritating when it's outside of the blood vessels in the brain. So um, that remains an area of a lot of interest. I guess the other thing I should mention is there's also been a lot of technological work on trying to detect hemorrhages with other technologies, whether it's ultrasounds or electrical impedance. The problem with those technologies that I've seen so far is the level of accuracy. So CT scan is like very close to 100% accurate in finding hemorrhage, and the consequences of missing it are so bad that if you develop a technology with 80% accuracy, um, you're not really doing very much to advance the field. People will come to the emergency room with this 80%, and they'll still have to get the CT scan. Maybe you delayed things with the other technology, but that hasn't stopped people from trying to develop methodologies. I just see it as a very, very uphill climb. All right, so people give well, you do have mechanisms in your own body. You have your own TPA that will actually break up clots, and that's why you sometimes see people get better spontaneously when a stroke starts, where people have TIAs instead of strokes. If it doesn't resolve, you can give endogenous TPA, which can either break it up or not break it up. And then, as someone mentioned in the chat, you also have mechanical thrombectomy, which we'll see in a second. Um, but then yeah, so I'll move on to that. With thrombectomy, And this is also, I think, an interesting example of technology development is that the idea about putting in a catheter and doing something to a blood vessel as blocked has been around for a long time. There's been balloon angioplasty for decades in cardiac vessels and in other vessels. Um, and the development of this in stroke really depended on but both very meticulous clinical trials and also technology development of thinking about it. So the biggest problem with the mechanical thrombectomy is that you could break up the clot, but then just send it into the brain further and just have it do more damage. So now their catheters will actually aspirate the clot, so we'll bring it back. Doesn't show really all the examples. There are ones that will actually put a balloon temporarily ahead of the clot, so it'll go through put a wire through the clot, put some device here to prevent clot from going anterograde, and then mechanically remove it. They'll sometimes actually kind of open a mesh into the clot that actually can retrieve it. So the clots are actually removed all the way back through an artery, and it can actually be studied if need be. So that's an important technology. There's a limitation, and here's another technological limitation that could see some development in the future, is that the size of the arteries that can be treated this way have to be the relatively larger areas in the brain. So once an occlusion occurs in a blood vessel that's too small to reach, then you're limited to the TPA, which was usually already given before an attempt at mechanical thrombectomy. So this is really only useful for what's called large vessel occlusion. Um, but of course, catheters could get smaller and steerable and treat other ones. All right, so if we talk about this example case, um, there was no hemorrhage or large vessel occlusion on a CT and also CT angiogram, which is often done early on to see where the level of the occlusion is. So it's received TPA, recovered some movement and speech ability, observed in the ICU for 24 hours. That's another monitoring thing that because TPA can actually increase the chance of hemorrhage. People need close observation. She started on aspirin and clopidogrel, which are both antiplatelet agents that work together to reduce the chance of stroke, but also increase the chance of bleeding. So there's a kind of timeline for how long people are on both agents. Then transferred to a regular hospital room. She was evaluated by physical, occupational, and speech therapists. Okay, so what causes stroke? And I think this would be hard to do interactively, but there are many things that can cause a stroke. This was an ischemic stroke. It could come from a blood clot from the heart, a blood clot from another artery, what we call artery to artery embolism. Um, it can come from narrowing of blood vessels, and then sometimes blood vessels narrow just to the point where they get so narrow they can't carry even a single red blood cell. A lot of times they're what are called cryptogenic, so finding the cause of stroke is actually, is a big area. People actually will walk around for a year with an implanted loop recorder to measure their heartbeat to see if they ever go into atrial fibrillation, which is associated with development of clots. But it isn't really well known if somebody has 5 minutes of atrial fibrillation for their whole year, does that mean that they need to be on blood thinners for the rest of their life? The risk is relatively less than if they're in atrial fibrillation half the time or all the time. What's the prognosis? So, I mentioned that other study we're doing with TMS and other measures to try to predict in this case, motor recovery later after stroke. In general, people with better function soon after stroke or do better later, but there are variable courses, and so we still need some work on forming a prognosis. What should be the follow-up? So does this person need any sort of treatment or therapy or any other medications? And then another interesting question is she had a blockage in a blood vessel. She got TPA, got better, but many of her neurons have died. They don't all die initially, they're ones that were what we call um, in the ischemic well, the core of a lesion, and then ones in the penumbra, um, and those in the penumbra may be damaged, but could go on to die or could not die. So over the several decades that there have been attempts to prevent neuronal death, there has not been a single agent that has been FDA approved or even had a successful clinical trial to prevent neuronal death. So, the idea is that there's some like cytotoxicity, there's kind of uncontrolled release of glutamate with ischemia, but anti-glutamine agents have all either not worked or had serious side effects like psychosis that limit their use. So we don't have a single neuroprotective agent, even though people have been thinking about it for decades. So that's a more pharmacological kind of treatment, although people even think about non-pharmacological agents to try to reduce the death after the initial insult. All right. Just going, back to the case. So someone like this would probably benefit from inpatient rehabilitation. Um, there's not like there are not really good studies that show that what goes on during inpatient rehabilitation, which is a lot of therapy by physical, occupational, speech, recreation therapists, others, neuropsychologists, that no one really knows what the sort of components of it that work best. And it is kind of a standard, and you can actually show that mortality is better for people who are discharged to inpatient rehab than to a skilled nursing facility. But we still don't really know what the best therapy is for this particular person. So this person would go to inpatient rehab most likely, and they would receive these therapies, and they would probably be doing better. But there wouldn't be a whole lot of technology involved in any of that. We'll talk about some of it later. All right. So, the questions I've been interested in asking for a long time um, relate to the neuroscience of recovery. So, there's reorganization of brain function support recovery. Reorganization has become like a bit of a word that triggers debates, but I think the what I'm meaning by reorganization is changes in synaptic strength, in strengths of connections, in brain activity in regions that change like which tasks they're involved in after stroke and after rehabilitation. Does experience shape recovery? We know that experience affects the brain. Again, the sort of pendulum of regarding adult plasticity as being non-existent to being there to being less there, is something we see in the literature a lot, and it's still not really well known, and partly because we still, I think, really don't have the tools to look at the human brain changes after stroke in a way that answers the questions we want to answer. So you can do functional MRI, you can do use infrared techniques to record activity. But in terms of actually doing things that have been done, like in the animal literature, of showing that there's dendrite outgrowth, there are new synapses, it's very hard to demonstrate that non-invasively. And then, this basic question that we know from developmental neuroscience about sensitive and critical periods, is the time after stroke a sensitive or critical period? There's basically been an assumption in stroke that the subacute period, meaning the first several weeks after stroke, is a sensitive period, that rehabilitation does more during that period than later. But there are counterexamples to that, and the strength of the difference in humans is really not very strong. In rats, it's absolutely true that it's known that in a rat you should not give intensive rehabilitation in the first few days, and it's also known that intensive rehabilitation after a year doesn't help a rat with hemiparesis. But that's not as clear, and actually some of those statements would be not true in humans. So just to kind of introduce the idea, this was actually the very first study that I ever did in the area. I used to work on invertebrate sensory motor integration in leeches. So this was my first foray into human studies. But I think the questions that we had here, I think are also relevant to technology. Um, how do people actually recover? So one idea is the idea that you're reversing diaskesis, meaning that the stroke affects a brain region that has connections to other brain regions. Those other brain regions don't have their normal input and they don't work normally. An example of this is the cerebellum. If you a large hemispheric stroke on the left hemisphere will cause a very large decrease in brain activity and brain blood flow in the right cerebellum. So it's cross-cerebellar diaskesis. And then this can change because there are homeostatic mechanisms that are known to actually normalize firing rates and excitability. Remapping, another somewhat controversial area these days, but a change in the location of the activated areas related to a task or body part. Formation of new circuits. Can you even if you don't have new long-range connections in the mammalian brain, can you actually get a new circuit related to a task, including those contra-lesional, so in the other hemisphere, it's very relevant to language recovery, which is strongly lateralized. And then new behavioral strategies. This is less controversial. It's very clear that people do have new behavioral strategies. The most significant example would be a right-handed person learning to write with their left hand if they have right hemiparesis. So that this is an old study, but a question that still is around is when you look at someone who's had a stroke, and this was people who had very small, we call internal capsule strokes, and look at the motor activation related to moving, in this case, the side opposite to this hemisphere, you see these bilateral areas of activation. So this was showing that as individual, which I think is borne out by experience that people with stroke have very individual patterns of activation. But how much of this activation actually supports the recovery and how much is just related to the fact that there's been a lesion? Okay, so I'll kind of leave that just as questions for you to think about. But give an example of a technology that was developed specifically for rehabilitation, and this is the rehabilitation robot. So these are three robots made by a company that no longer exists. Interactive Movement Technologies. It was developed at MIT, so you can see the joke there with the acronym. But this was a company that was in Watertown, Massachusetts. This was the original MIT Manus robot, a planar robot, what you call an end effector robot, so very quick for someone to set up um, and put their hand in there. It supports the hand. They can move a handle around in a plane, and it moves a cursor for a sort of video game like activity. There's also a vertical robot that was developed that ended up being not useful in many ways, maybe dangerous. And then a wrist robot, which was a really nice design of a 3 degree of freedom robot to train wrist movement. There's a grip module developed for this. So, what happened with these robots? We used them in a variety of clinical trials. They were the first installation of these robots was at Burke Rehab in Westchester, New York. They actually showed effectiveness in acute inpatients, rehab. At University of Maryland, they were showing effectiveness of a planar robot in short-term rehab. There's a VA cooperative study, so a large multi-center study funded by the VA that showed that there was a significant improvement in motor function. It was relatively small, and worse, it was actually the same as if you used non-robotic therapy that was similar. So there's nothing magic about the robot. The robots, just looking at their what they look like, they allow you to move to accomplish goals on a screen. They also have motors that provide forces, guiding forces that help you get there if you can't do it yourself. So that's basically what, the unique feature of the robot is. But a therapist could also help you get to a goal. And then it's a question about how you sort of apply the labor to get that kind of level of practice. So we did a variety of other studies with the combinations of robots. I won't talk about them at this point, um, but we were able to yeah, like I said, we rejected the vertical robot, um, and likely the planar robot works better than conventional therapy for those who are more impaired because all those guiding forces that it applies lets people practice hundreds of repetitions an hour in a way when they're probably doing like about 20 when they're actually really working with a therapist. Um, we're actually also interested in what kind of brain changes occur with the robotic therapy. I think for the sake of time, I'll kind of skip through this relatively quickly. But we did do, we talked about the combination of TMS and rehab diagnostically. We did determine whether people had motor voc potentials before going through the therapy, and we also looked at brain imaging. Yeah.
Sorry.
Were you trying to ask a question, or was that just no?
Right now, I thought that it should be like after session or something.
I think
I think the person is just
yeah, unmute it, just
Yeah.
unmuting it. Right. Okay.
All right,
Right.
it sounds like you're looking at the time, but we are trying to wrap up at 4 p.m. So
Right. Right. Okay. That's what I thought. Okay. So, but just to show that, because you're asking what TMS is good for, we did some of this mechanistic work. We did resting state connectivity, which showed changes with the input. So the last thing is, about TMS is that we are continuing to do work combining stimulation that's tied to practice. So activating brain circuits at times um, when we expect it to be useful to get Hebbian plasticity during activation. And so what we're showing here is someone with stroke. We're stimulating either sham stimulation or over their primary motor cortex, doing multiple blocks of training and showing that their peak velocity increases when we combine the stimulation with the training. So that's a kind of promising kind of effect that we're trying to exploit more now. So the last thing I'll talk about is BCI and assistive devices, just to get you thinking. Um, so, this is from the work that's going on here in Pittsburgh on people who've had spinal cord injury who have electrodes implanted and who are controlling a robot with their hands or even to get sensory input when they touch the device. So this is, of course, um, an exciting development. People find it very, very compelling. I think let's see, yeah, the real question about this is how to develop practical assistive devices for people who can, say, reach and feed themselves. Will it be direct cortical BCI? Will it be EEG-based BCI? Will it be muscle-based BCI? Or, and how much can artificial intelligence add to anticipating people's needs and helping them do tasks, even if they're not controlling every aspect of the task? So that's a very short introduction to the problem, which I think is something that could be solved using a combination of current technology, I think. Um, so then just summing up, I think when we think about the potential needs in stroke, even things I haven't mentioned, early diagnosis of stroke type to determine treatment, new technologies to restore blood flow, even when the blood vessels are not large blood vessels, neuroprotection, and other kind of pharmacological agents that affect the recovery process, better decision making regarding neurorehabilitation. We've made a little foray into this, but can you get better information than just a kind of formal exam, figuring out what people's needs are? And then once you figure out those needs are, can you optimize or enhance their practice in a way that actually benefits them most? Right now we just use a kind of school of thought, usually called neurodevelopmental, that has not been proven, interestingly. And then finally, what's the potential for assistive devices? Because the biggest problem in recovery is those people who have the most severe injuries, who are completely aphasic or complete hemiparesis, or even locked-in syndrome. So basically tetraparesis. So how do you provide assistance to allow people to be independent even when they can't activate muscles or use language. So I'll stop there and see if there are any questions.
All right, thanks so much for your talk. We have time for just a couple of questions, and then while people are thinking about their questions, I'm going to plug next week's talk. We have What is a medical device? Does my technology need to be a medical device? With Dr. Robert Allen, who formerly of the FDA. So we have one question in the chat.
Yeah, I saw it. Yeah, yeah. So could could TMS help with excitatory? So that's certainly something that people have proposed. Um, there a lot of reasons to think that it might actually do the reverse. So you're activating, neurons. In fact, actually, probably vagal nerve stimulation might be more helping with excitotoxicity. You would want to do things that would actually reduce metabolic needs. TMS, if you could get remote effects, maybe, but in generally, try to avoid that. Now, we are doing TMS in the subacute period now with the Verify study, and I think one thing it had to demonstrate is that you don't have any ill effects from doing that. So it probably doesn't hurt, but yeah. So it could. I mean, TMS does something. It's one way to get energy into the brain, but I think more of the efforts have focused on trying to reduce activity in the brain.
We have a raised hand as well.
Okay. Sure. Go ahead.
Hey, George, can you hear me well?
Yes, I can.
Hi. Thanks so much for the talk. So, follow-up question regarding the TMS. How in the improvement that you see in performance, I'm just curious, like if you do the TMS stimulation, do you think you can also improve other performance that is not like upper extremity, like can it also, generate plasticity that is also applicable to gait, for example?
Yeah, I mean as yeah, haven't really done gait work but yes, I mean I think gait is very different than upper extremity control from a motor control standpoint. Um, but there's no reason why you couldn't think of that, and I think people are doing that. I think the big question is stimulating the right part of the brain at the right time to enhance control. I mean, I really have no doubt that there's some stimulation paradigm that will make things better. There are probably some that will make things worse, and it's been somewhat difficult to find which, especially if it takes multiple sessions to get there. So there is a bit of a sort of parameter exploration problem in the field. Sophia.
Hello, thank you for the wonderful talk. So I was wondering if you could expand on what you said before with AI and the role in predicting movement and treatment.
Right. So theoretically, if you get a lot of data about a patient, um, and you had a large database of patients who had stroke, and particularly of like what they got after stroke, you should be able to find like those factors that could individualize um, improvements, rather than decrements. I mean, so, in the old way of doing things, I mean, it was people would do a survey and find like that people who are on depressants medications like benzodiazepines after stroke did worse, and so we try to avoid those now. So that's a simple way. But if you think about all the medical information you have, one problem is that we don't actually really have a good recording of what happens to people during rehab, like what they do. I mean, of course, the therapists like record. We did 15 minutes of ADL, activity of daily living work, but in terms of what they actually did, we don't really know. And so even if you had like, some kind of recording of what people are doing and figured out, even for the individual, what's working best, and we really don't have anything like that. So I think that's where that's where there's actually room for development.
Thank you.
Yeah, Alexis.
Hear me?
Yes.
Thank you for your talk. A while ago you said that you were explaining when you introduced acute stroke that there are CT scans, that there are MRI scans that but the MRI is not as good. It's about 80% compared to CT, which is 100. And then that there are some still people that are trying to develop this kind of technology. What do you think would be the motivation to continue developing this without like thinking, oh, this work is useless, or that it's not as good as what it there
Right.
currently is right now?
Right. So I think yeah, so the problem is that I think it's hard to imagine a world in which every ambulance has a CT scanner. Um, it's right. So, there's a certain practical level. So if you're thinking, I think the room is there for an alternate technology that will give you information. And, just because something doesn't work well at first, I mean, doesn't mean that with refinement, it can't be better. So MRI, I mean, in some ways, I put that forward because I think that actually that might be a technology that could work. I've been impressed. I've mostly seen them on grant applications of the images from portable MRIs. The problem of localizing blood, I mean, that's more of a human sort of problem. So again, AI could, diagnostically solve that problem by looking at the signal characteristics, of subacute blood. Um, Right, and whether like some ultrasound method or I didn't even start talking about developments in focused ultrasound, because that's a huge area for non-invasive brain. But yeah, no, I think that's where we drive at. And just to be the skeptic, is that sometimes the thing that helps the most in this case is actually just human organization. So in Finland, I remember we heard a talk 10 years ago by the director of stroke in Helsinki, and so they had reduced their time. What's measured is what's called their door to needle time, like how long it takes before someone gets the treatment. Once they go through the doors, it reduced it down to like 21 minutes for stroke patients in Helsinki. And that's like enviable numbers for anywhere else. And they did it completely by organization of how people talk to each other, and where the ambulances go. So anyway, it's you have to balance the technological developments with the kind of system developments. But I think there's definitely room, and that's why I think so many companies have been actually working on technologies that to detect hemorrhages early on. Right.
All right. Uh, Thank you to all of our attendants, and let's thank our speaker one more time. Some
Yeah,
magic
it's
work
fun.
happening
Thanks.
behind the screen. All right. It was
Thank you, George.
great to see everyone. And remember, we have the same Zoom link every week, every Tuesday at 3 p.m., except for CMU holidays.
Right. Thanks. Bye.
Thank you.
All right. Bye, everybody.